most of the physicians believe that infections is quite prevalent in diabetics. So I will start speaking about infections and diabetes today. We'll try to answer two questions and get very brief presentation about some specific infections in diabetics. The first topic we will speak about is that are really diabetics are more prone to infection. The second part will be about what are the mechanisms making the diabetics more prone to infection. And lastly, we'll speak very briefly about some specific infections in diabetics. Are really diabetics more prone to infections? This is the first point we'll speak about. In fact, there is wide acceptance by both medical profession and general public that diabetics are more prone to infection. Is this really true or not? A lot of studies have been done about that. Many studies have been done about that. I do not like to be boring and speaking about all these studies done about diabetes and the probability of infections in them. But the results were quite controversial according to the type of infection there. And so the investigators have reached to a division of infections in diabetics into 4 groups. The first group include these infections which were considered. The first group with the infections which are proven, which carry clear evidence of association between these infections and diabetics. The second group include infections which are considered to be having probable association with diabetes. And these are the infections in which diabetic patients constitute at least 30% of patients with these infections. The third group include infections which are considered to have possible association with diabetes. And this was defined as infections in which diabetics are from 10 to 30% of the patients with these infections. The fourth group include infections which were found to have no statistical difference between diabetics and non-diabetics. The first group that include infections which have proven association, clear-cut association with diabetes. And this included 2 infections only, tuberculosis and bacteriuria in females. The second group with probable association, as I told before, that at least 30% of patients with these infections were discovered to be diabetics. And this include malignant otitis externa, rhinocerebral mucormycosis, emphysematous cholecystitis, emphysematous pyelonephritis or cystitis, acute papillary necrosis, perinephric abscess, fungal urinary tract infection, gram-negative pneumonia, necrotizing soft tissue infections, and food ulcer-related infections. The third group include these infections which were considered to have possible association with diabetes. And as I said before, these are the infections in which diabetics constitute from 10 to 30% of the patients with these diseases. And this included staph pneumonia, solitary liver abscess, bacteremia, either due to staph, due to Streptococcus epilepticus group A, due to gram-negative septicemia. Mucocutaneous candidiasis is also in this group, and cryptococcosis, histoplasmosis, blastomycosis, coccidioidomycosis, and osteomyelitis. The fourth group, which included the infections which have proven no association with diabetes. And this includes pneumococcal pneumonia, hepatitis B, bacteriuria in males, carbuncles, and boils. And this is an astonishing result of these studies because most of the clinicians believe that carbuncles and boils have great association with diabetes, which by studies have been proved not to be true. Carbuncles and boils have the same incidence in diabetics and non-diabetics. Why diabetics are thought to be more prone to infection? In fact, mechanisms of affected immunity in diabetics can be classified into 2 groups of factors. Factors related to the host, to the diabetic host, and factors related to the organism. The factors related to the diabetic host includes hyperglycemia, neuropathy, either sensory, motor, or autonomic. The third group is due to vascular insufficiency that's seen in diabetics, either on the macro level or on the micro level, and skin and mucosal colonization with different forms of pathogens, especially Staph aureus and Candida albicans. There are other factors related to the organism that is responsible for infection. And many examples are present for that, and many organisms find that the hyperglycemic with or without ketosis is a very good medium for them to develop and flourish in diabetic patients. The effect of hyperglycemia on impaired immunity, in fact, researchers of immunology have studied poorly controlled hyperglycemic rats, and they studied the neutrophil function in these rats, and they found that most of the neutrophil function have been affected. Chemotaxis, adherence to the endothelium, phagocytosis, intracellular bactericidal activity, and opsonization. All these are decreased in diabetics, getting them of less immunity. The effect of vascular insufficiency, in fact, vascular insufficiency either on the microvascular level or macrovascular level leads to local ischemia in tissues. And this local ischemia enhances the growth of microaerophilic and anaerobic microorganisms. Also, the ischemic environment depresses the oxygen-dependent bactericidal function of the leukocytes, and also decrease local inflammatory response and decrease the response to the antibiotics. The tissue is ischemic, getting less oxygen and getting less blood supply, and so can be affected in that manner. The effect of neuropathy, especially on the sensory level and autonomic level. Sensory neuropathy leads to a limb that is not sensing well. So minor traumas or abrasion in a patient with sensory neuropathy was unnoticed due to weak sensation resulting in ulcers and diabetic foot infection, while the patient is not sensing that and is not feeling that the infection is going on in his limb. Also, autonomic neuropathy can cause propensity infection in many ways, and the most prominent example is that which happens in the urinary tract, as autonomic neuropathy in the urinary bladder and in the urinary system in general lead to urinary stasis, which makes good medium for the organism to develop in that static region. Skin colonization also has a role in getting the diabetic patients more prone to infection. Patients with diabetes, and especially those who inject insulin, often have symptomatic nasal and skin colonization with the staph aureus, which most likely to be methicillin resistant, that's MRSA, and also predispose the skin and incisional staph infection and bacteremia that can cause distant infection in distant organs. The effect of the organism-specific factors that help infections to develop in diabetics. Many organisms can find the hyperglycemic, ketotic, or non-ketotic environment in diabetic patients very good medium for them to develop and flourish and cause infection in these patients very easily. The most two prominent examples are Candida albicans. Candida albicans, the glucose-inducible proteins present in diabetic patients promote adhesion of Candida albicans to buccal and vaginal epithelium, which can impair phagocytosis, giving the organism an advantage over its host. Rhizopus species also, which is a type of fungi that develop in different parts of the body, especially in the nasal area. The Rhizopus fungus possess an enzyme called ketone reductase, which helps Rhizopus to flourish in high glucose acidic conditions typically present in diabetic ketotic patients. Now I will try to give very brief discussion about some specific infections that is seen in diabetics. We will pass very shortly speaking about malignant otitis media, otitis externa, mucormycosis, emphysematous cholecystitis, emphysematous pyelonephritis, asymptomatic bacteriuria, and foot infection. The first of them is malignant otitis externa. Malignant otitis externa is an infection that occurs in the soft tissue tract surrounding the external ear. The symptoms start in the form of ear pain and discharge, accompanied by polypoid mass of granulation tissue protruding from the nose, from one ear side. Characteristically, there is no fever and no leukocytosis. Imaging usefulness is very low in these cases, especially in the start, because no bone affection is there. All the affection is to the soft tissue mainly. Biopsies taken from these patients showed significant intimal proliferation, which gets an indication that this infection has something to do with microangiopathy in diabetics, and which can explain why systemic inflammatory response like fever and leukocytosis is not there. The organism here is usually Pseudomonas aeruginosa. Treatment, we have to treat as soon as possible by surgery, debridement of that area with anti-pseudomonal, antimicrobial, anti-pseudomonal antibiotic, ticarcellin or piperacillin. Here in Bahrain, piperacillin is present, and we have to add to that aminoglycoside. And we have to continue for that treatment for at least 6 weeks. Many studies have suggested that topramycin is much stronger than gentamicin or amikacin as an aminoglycoside. So the medication that is typical in this case is to continue after debridement to continue on aminoglycoside like piperacillin with topramycin for at least 6 weeks. The next infection we will speak about is mucormycosis. Mucormycosis is inflammation complicated by necrosis of the nose, the nasal area, nasal turbinates, and the nasal septum. The organism is usually mucorfungus, although rhizobus and Abacidia have also been blamed in these infections. Treatment of that condition depends on as early as possible and as extensive as possible debridement of the affected tissue together with amphotericin B, lyophilized amphotericin B. Of course, prescribing amphotericin B is a bit difficult in this patient because many of them have impaired renal function, so we have to correct the dose. Complications of this disease are, the main complication of this disease is extension, very rapid extension. It can extend to the nasal sinuses, can extend to the orbit, and lastly can extend to the brain, either through the orbit, through the vessels, or through the cribriform plate. These patients, if not treated, will die in 1 week. So although it is a rare disease, we have all, as a GP, as physicians, as otolaryngologists, we have to be very aware of it, and we have to put the clinical diagnosis very quickly, because interfering with aggressive treatment very early is crucial for these patients. The next infection I will speak about is emphysematous cholecystitis. Emphysematous cholecystitis is characterized by a radiographic picture of gas in or around the gallbladder. Diabetic individuals appear more predisposed to that infection. This is a very simplified schedule about differences between emphysematous and ordinary cholecystitis or non-emphysematous cholecystitis. Males are much commoner than females in this, which is contrary to non-emphysematous cholecystitis. Males are 71%, while it is 27% in non-emphysematous cholecystitis, so males are the majority. Gangrene occurs in 74% of cases, while usually in non-emphysematous cholecystitis, ordinary cholecystitis, is 2.5. So it is 30 times commoner in emphysematous cholecystitis. Perforation also is more than 20%, about 21%, and it is 4.5% only in ordinary cholecystitis. So it's 4 times commoner in emphysematous cholecystitis. Mortality is quite high, it is more than 15%. While in ordinary or non-emphysematous cholecystitis, it's less than 5%. So it is at least 3 times probable in emphysematous cholecystitis. And if the patient is above 10 years, if above 60 years, it is more than 10 times common to happen. Pathogenesis of this necrotic infection is, beside the infection, is arterial insufficiency, which plays a major role in the position and in the necrosis. These patients have prior cholecystitis in 40% of cases, and 50% of cases having calcular gallbladder. Treatment is cholecystectomy within the first 48 hours of the presentation, followed by broad-spectrum antibiotic for at least 2 weeks. So it's a recommendation that all diabetic patients with gallbladder problems, either calcular or non-calcular, should deal with very seriously from the start. Cholecystectomy should be done for diabetic patients as soon as possible. Emphysematous pyelonephritis is not so much different from emphysematous cholecystitis. It's also a gas infection with a gas-producing organism that's complicated by necrosis. So it is a necrotizing infection. characterized by gas production in or around the kidney. It occurs in 70% of reported cases. 70% of the reported cases are found to be diabetics. In fact, other series suggest 27%, others suggested 45%, but generally it is much more common in diabetics. Abdominal radiography frequently show motile nuisances overlying the kidneys. E. coli is a main pathogen, like other ordinary urinary tract infections in general. Other gram-negative organisms can be also implicated in this infection. Surgery is resort to or is needed if the patient did not respond to treatment within few days. The next infection is asymptomatic bacteriuria. Asymptomatic bacteriuria is defined as presence of more than 100,000 CFU, coliform units, of organism in 1 milliliter of urine in 2 consecutive samples of clean catch urine of the same strain of organism. Why asymptomatic bacteriuria is common in diabetic females in general? Here we are concentrating on diabetic females. The first cause is hyperglycemia that gives a good environment for the urine, for the organism to develop in that urine, and the second is a stasis of urine due to autonomic neuropathy, as we mentioned before. Organisms is almost like non-diabetics. E. coli is the main organism, although other gram-negative organisms are also culprit. What is the significance of asymptomatic bacteriuria? We are concerned with asymptomatic bacteriuria because it's a potential threat to the urinary tract that can extend upward, cause cystitis, pyelonephritis, or even perinephric abscess. Now, what is the treatment of asymptomatic bacteriuria? In fact, a lot of studies have been done about asymptomatic bacteriuria in diabetic females, and if we are going to treat it or not. But most of the consensus now is towards not to treat the asymptomatic bacteriuria for 3 reasons. The first reason is that most of the studies have done about eradication of organisms in asymptomatic bacteriuria found that after eradication, 50% of the patients regain the organism within 6 weeks, and 90% of them after 6 months, and 90% of them will regain the organism after 1 year. So the organism will be regained in spite of good eradication of the organism. The second cause of not to treat is that urinary tract infections in diabetic and urinary tract problems after eradication or in patients with asymptomatic bacteriuria or without asymptomatic bacteriuria found to be the same. Even one study reached that patients with asymptomatic bacteriuria are less liable to get upper urinary tract infection than patients without asymptomatic bacteriuria. And some authors suggested that it may be a protective commensal in the urinary tract. The third cause is that long-standing follow-up of these patients found that there is no affection of asymptomatic bacteriuria on the kidney function on the long run. So most of the authors now believe that asymptomatic bacteriuria in diabetic females needs not to be treated. The last infection that we'll speak about is the famous diabetic foot infections. Diabetic foot infections, in fact, form a fluoride example of how can organism-related and host-related factors can interplay together in the pathogenesis of that infection. The infection occurs because that patient has non-sensing limb due to presence of long-standing sensory neuropathy, have been exposed to abrasion. He did not feel the abrasion or the minor trauma. This abrasion or minor trauma happened on skin that is heavily colonized with Staph aureus or other organisms that enter the body, found hyperglycemic medium that's very good for them to flourish, and found an ischemic limb which have very low level of healing, and even the antibiotics cannot reach easily. So the patient mostly do not feel the minor trauma or the abrasion that happens from the start, and he is confronted with a wide extensive lesion that he was not acquainted with. So this is a very good example of that. Of course, we all have faced a lot of cases of food infections, and speaking about their management is lengthy and should be discussed out this forum. But in this year, on May 12th, the American Society of Infectious Diseases, the IDSA, have published very good review about the recent guidelines for management of treatment. I invite all my colleagues to return to that. Thank you very much.